So this is module 1.1 on chest pain. So this case starts with a 60-year-old female, history of coronary artery bypass graft, presenting with chest pain, which is a pressure radiating into the left arm and jaw. This pain is a 8 out of 10 for 2 hours. Pain is better with rest, it's worse with exertion, associated with nausea, diaphoresis, epigastric pain. Patient denies any vomiting, headaches, numbness, or tingling. So in terms of an HPI, one of the proper formats is to do a QRST or QRSS format, starting with the quality, which is a sharp pressure, a stabbing, or a discomfort, radiating, whether it's into the jaw, the back, or the left arm, could be into the stomach or the abdomen. Severity, rated on a scale of 1 to 10, 10 being the most severe. Timing, sudden, gradual, constant, or intermittent. Associated symptoms, which in this particular case, positive for nausea, epigastric pain, diaphoresis, denies any headache, numbness, or tingling. So this is your QRST, or quality, radiating, severity, and timing, or a QRSS, which is quality, radiating, severity, symptoms. Several different ways to properly format your HI. Very important to note that always look for an EKG with patients that have anginal equivalents. Angina is a medical term for chest pain. The equivalents are when patients have different symptoms that would trigger someone in triage or a physician to get an EKG, whether that's jaw pain, arm pain, epigastric pain, whether it's dizziness, diaphoresis. If the patient has high blood pressure and they're elderly, just make sure that you're noting and looking for EKGs and all those particular symptoms and making sure they're documented properly. Also document the cardiologist, the primary care doctor, the last stress, and the last cath. Very important to note, as we get busy as physicians, there's several chest pain patients in the emergency room at one time. It's difficult for us to keep those particular facts straight, so it's important to keep those notated on the chart. Physical exam. This patient's general exam is diaphoretic or sweaty, uncomfortable, and in distress, whether that's mild, moderate, or severe. On the heart exam, there's a murmur. We rate those on a scale of 1 to 6. Typically, a 2 out of 6 is the most common murmur that we'll hear in intensity. For the lung exam, we notate the patient's using accessory muscle use. So they're shrugging their shoulders. They're obviously in distress trying to get that breath of fresh air in. There's rulls or crackles on exam. That just indicates that there's some fluid in the lungs. Could be significant for congestive heart failure or a pneumonia. On our leg or extremity exam, patients exhibiting edema and calf tenderness. Edema is graded on a scale of 1 to 4. So we'll say +1, +2, +3, or +4. And that's how we will grade edema in the legs or swelling in the legs. Our differentials for this patient: acute myocardial infarction or heart attack, acute coronary syndrome, which is a STEMI, non-STEMI, unstable angina. There's 3 different aspects. Acute coronary syndrome is kind of the blanket term that encompasses acute myocardial infarction, as well as different terms that would indicate someone is having some sort of cardiac issue that's causing the chest pain. So a STEMI is an ST elevated MI, and you'll see that on the EKG. If there is a STEMI, all the bells and sirens go off in the emergency room, and the patient needs to go directly to the cath lab. It's a very time-sensitive diagnosis. A non-STEMI is when a patient has elevated cardiac enzymes in their blood, but their EKG is not showing anything such as a STEMI where they need to go directly to the cath lab. Non-STEMIs, non-ST elevated MIs, can be admitted and they can be taken to the cath lab at a further time. Unstable angina is a patient with chest pain in the emergency room that is not resolved with morphine, nitro, or any of the other means we use for pain control. If this patient has ongoing pain or unstable chest pain, they need to go to the cath lab. The other differential is PE, or pulmonary emboli, which is a blood clot to the lungs. Dissection, which is an aortic dissection. These patients, again, very critical. They have sharp pain radiating through to their back. It starts to migrate from their chest to their belly, or their belly to their chest. Migrating pain is a very key term notating dissections. A pneumothorax, or a collapsed lung, typically picked up on a chest x-ray. We can pick this up on physical exam as well by listening to the lungs. Esophageal rupture, a very rare diagnosis. You can get this after a endoscopy. Some people do have this spontaneously as well. Costochondritis and GERD are kind of the last two differentials, non-acute, but can equate to why the patient's having chest pain in the emergency room. Costochondritis is rib pain, worse with inspiration when you expand the chest and rib muscles. GERD is just gastroesophageal reflux disease, or reflux. So on the EKG, there's three areas that you must document in terms of when we are telling the scribe how to interpret an EKG. There is a particular order in which we have learned how to interpret it, and sometimes we will go out of order, but the proper way would be rate, rhythm, axis, block, hypertrophy, or ST changes. We will also notate Q waves, QT intervals, PR intervals, T waves, whether it's a paced rhythm. There's other things that we may call out in terms of what you need to notate. So make sure you always look for repeat EKGs. Ask the doctor if there's been any repeat EKGs. In some of our documentation systems, there's little cues actually on the EHR that another EKG has been ordered. Make sure you're just following up and you're constantly keeping on pace with EKGs. If the patient's pain gets worse, we will always order a repeat EKG. So if the patient is in the room and their pain's controlled, then all of a sudden it starts to come back, we want to make sure we're able to capture that on a 12 lead, so there will be a second EKG. So labs that we use, there's the myoglobin, which is the first cardiac enzyme that rises, very nonspecific, and sometimes as physicians we don't even order this because it's so nonspecific. A CKMB, which is a cardiac marker that is a little more specific for the heart, and it rises earlier than your troponin, the troponin being the most specific cardiac enzyme. Some of the systems that we use in the hospitals, there's an iStat machine, or what we call a quick blood read. So there are some times where a troponin will come back very soon and it won't be uploaded into the system. Just make sure you have captured that troponin level and it's notated in your documentation. D-dimer is a non-specific lab used to diagnose or rule out a pulmonary emboli, which is outside the scope of this lecture, but it is something that's involved in the chest pain workup. So on X-ray, for our diagnostic radiologic studies, we're looking at the heart side, whether they have cardiomegaly or an enlarged heart, a wide mediastinum, which can indicate there's some sort of dissection that should clue us in, the lungs, whether there's fluid or a collapsed lung or a pneumothorax. There's also the modality of a CTA, which is a CTA of the chest, looking for a dissection or a pulmonary emboli. It's a CAT scan. And if they are unable to receive IV dye, in particular cases where a patient has renal or kidney insufficiency or failure, we will order a VQ scan where they go down to nuclear med. There is actually a radioisotope tracer that they breathe in, and it's able to correlate on their chest x-ray and see if there's a defect where the uptake of the tracer is showing there may be a pulmonary emboli. So not a very specific scan, obviously CTA being the most specific, but the VQ scan is measured in low, intermediate, or high probability for PE. So if patient comes to emergency room and has received aspirin prior to arrival, make sure you're documenting the aspirin was given at what particular time. So if the patient was giving aspirin while in the squad, notate what time they were in the squad and given the aspirin. There needs to be a time documented when the aspirin was given for various metrics that we use in the emergency room. If the aspirin's given in the emergency room, great, just notate that the aspirin was given in the emergency room at such a time. So reavals, it's stress, reavals, reavals, reavals. If a physician walks by a room, looks in and says, how you doing? Make sure you're able to document how that patient's doing. If the patient's blood pressure goes up, if the patient requests more pain medication, anything that involves that patient, there should be documentation on the chart stating that we have done some sort of reevaluation. For medical decision making, the very most important section of the chart, you can document this in a narrative fashion. So patient's first set is negative of cardiac enzymes. They're still at risk. We discuss with the patient that they need to stay for serial enzymes. The patient agrees to stay, does not agree to stay, and patient's alert, awake, oriented, not intoxicated, able to make informed decisions, and of sound mind and judgment. So very important to put that narrative portion in, notating the fact that we have talked to the patient about their risks still, and they are on board with the plan. Last slide, so disposition, whether this patient's going to the cath lab, whether this patient's going to admitted OBS, admitted inpatient, cardiac step down, and who we have spoken to, whether it was a cardiologist, whether it was just the hospitalist for serial enzymes. These are the various dispositions a patient can have. Last thing I want to touch on was STEMI. Just document, document, document. You're documenting the times, you're documenting all the modalities, whether that's heparin drips, nitro patches, beta blockers, what time we had called the STEMI, and the various phone calls that are involved. This is a very, very in-depth chart in terms of the various things you'll see as a scribe. So when you hear that term STEMI, just make sure you're notating and time stamping everything that is done and making sure it's a very full chart, very easy and clarified, so it's easy to read for your physician, for all of the consultants, and it just flows properly. Okay, that concludes our chest pain module 1.1.